The doctors are.
Oh, that's okay.
Oh, I was gonna say, well, what about the doctors on top can do both?
Yes,
So
our
that
physicians are
part
with both.
Wouldn't change. The team members beneath them would change.
Yes and no.
Right.
Because the physicians are rotating. So with palliative care, we have two main physicians, Dr. Kate Tyndall and Dr. Sandra Carlson, that are primarily palliative care. And then we have a lengthy list of physicians that are with Hospice Austin, based on territory.
Mhm.
So you may see different physicians with palliative care, and with hospice, once they're on that, they have a specific doctor, unless that doctor's out of town, it will be the same one, but most likely different than palliative, but they're all literally in the same office, same company,
So
so
they can get information
Yep.
and
There's
coordinate
no
care.
gap there.
Right.
In
Where
transfer.
it seems- Yeah.
Yeah, and then a referral moving over is seamless too.
Yeah.
Going from Austin Palliative Care to Hospice Austin, super easy, quick, because we all communicate so regularly,
Mhm.
it's immediate, at least.
Yeah, right.
So, I'm just word vomiting. Does anyone have any other questions? I don't want to.
But since I forgot to record it, you're just gonna have to start over from the
Yeah.
beginning.
Take two. Well, and with hospice, what's covered is durable medical equipment.
Yeah, right.
Bedside commode, hospital bed, walker, wheelchair,
Mhm.
meds related to why someone's on service, adult
understand.
briefs, right?
Mhm.
Adult briefs, lotions, even those like glycerin sticks, I mean, whatever's needed.
Right, not provided with with palliative care in general. But yeah, that is provided with hospice. So that's another thing that caregivers can notice in a hospice referral. They can notice that and tell their nurse practitioner with palliative care, whoever the nurse, and say, I feel like we need a hospital bed and we're starting to, get to where we want some Pampers in the house. And it's
Right.
like, that is a red flag, or not a red flag, maybe like a beige flag. Like, okay, I think we see something here that maybe we should start having the discussion of hospice, so.
Yeah, and respite care is provided through hospice. And
Yeah, and that's a big
Yeah.
thing too, because respite, does everybody know, you all know what respite is probably? It's just a length of stay for X amount of days for your loved one to be in a facility or a community that, can watch them 24/7, so you can have vacation, you can go away for whatever it is, and then someone can be technically babysitting your loved one and making sure, just doing the same kind of care that you would, but then also those nurses there on site. So yeah, respite is a huge benefit. Something with Hospice Austin that's very unique to Hospice Austin is Christopher House. I don't know if everyone already knows about that, but it's, and GIPs, it's inpatient unit, and it's, what I like to put it, it's a house that's a hospital inside. So they have the 24/7 care, they have everything a hospital would have, but it's limited. How many rooms is it exactly?
15 beds.
15.
But people are constantly rotating out, whether they get the symptom managed for why they're there, if it's like you're having uncontrolled pain and you're at home, but you could be better controlled in a clinical setting. An option is to go to Christopher House. They do, a new plan of care and get everything, the meds fixed, and then they send you back home, or people do pass there. So it's really hard to say, is there a bed available? It varies.
Yeah, you have to ask and we will tell you 1 hour and it's gonna change the next hour.
Yeah.
Yeah,
But
it does. And what's so cool is like they look through the lens of comfort. So they're not coming in to take blood all the time and wake you up. I mean, it truly is what is going to bring comfort. It's comfort care. I think when all 15 beds are full, there's 3 nurses staffed, I believe.
probably right.
And so it's covered. There's physicians that rotate there for us. Families can come stay. There's no visiting hours. You come at any time. You can bring your pet. I remember when I first started with Hospice Austin, somebody brought an iguana.
Oh.
And I'm like, okay. And he was like, yeah, he gets loose. So they would find this iguana like going room to room. And I'm like, I don't think we can do that, sir. Like, can we put him in a cage? What can we do? But I won't say anything goes, but kind of anything goes. Because
too.
yeah, each situation's different.
Mhm.
And We have different teams. So a nurse that goes to the homes is not working at Christopher House or going to the hospital, and that works well. I think since we've been around since 1980, we kind of had different things come along. We've been able to work out the kinks a bit better.
So is Christopher House private pay or something?
So it's covered under the hospice benefit, like Alyssa said, general inpatient hospice. So if you need that level of care, like you need to be in a clinical setting, Medicare pays for that. Just like they would if you're in the hospital and you're on hospice. And that covers everything. Yeah.
So it's considered like a skilled nursing type thing? You couldn't just, if you were a walkie-talkie kind of dementia person and needed
Right.
no medicine or anything like that, you couldn't just go stay
Right,
there while
right.
someone's on
It's
vacation?
acute care.
Okay.
Yeah, for whatever's going on at that moment.
Okay. Do you know any other facilities that, so Kathy mentioned San Gabriel that they're doing respite at. Do y'all know any other facilities where people can?
Most of them do respite, most do. I would say probably 90%. So
Just of
you
any
have-
nursing facility?
You just have to have a respite contract with, like the hospice has to have a respite contract with them. If we don't have one, say your spouse is on Hospice Austin and you guys found a facility that you like and it's close by and we don't have a respite contract, we can certainly ask and maybe get one started. That might take some time. It just kind of depends on the situation, but that's where your social worker comes into play. You say, hey, send me a list of places for respite in this area and we'll send you some and then you can look through it. And that's usually the best route to go.
Sometimes personal care homes do it. There is one
Yeah.
in Cedar Park, Shenandoah Villa. And it's a really nice place. It's always well taken care of. It smells good. The
That
food's
counts for a lot.
good.
That
Yeah.
counts for a lot.
Yeah, and so she does respite too, but in order to prepare for respite, like Alyssa was saying, the social worker gets all that set up because you want to get records over there and what meds are they on and that kind of thing. But yeah, so they don't, with Christopher House, it really is symptom management,
Okay.
what's going on at that time.
So is it always a skilled nursing? That memory cares wouldn't do respite, would they?
That's a good question. I would have known that a year ago when I was with the hospice team. That just slipped my mind. That's a good question.
That is a good question. I would think so,
Mhm.
but I don't know. And like Alyssa said, if we don't have a contract there, we can get it pretty quick usually.
Okay.
I would think
That's
so.
a really good question. I would think they
Lots
would.
of skilled facilities don't have a memory care, but they have like a locked unit. It's just, those are hit or miss. Again, I would ask your social worker, but I was asking if, whose husband is it that's in respite?
Kathy's.
Yeah. I was asking if she was with hospice or if he was with hospice, but, because most of the time that's where we see it. So if they're not with hospice, it's hard to find, you don't have your social worker, so.
Right.
Yeah, that's a good question though. I need to figure that out again.
I think just if you have a facility in mind, just calling them and say, hey, do
I'm
you-
trying to think the facilities where I was, I don't remember, well, we never had beds,
oh, okay,
so it wasn't
yeah,
a thing. But even the assisted living when I was at Spicewood,
right, yeah,
we were always looking for ways to fill, but I don't remember anybody coming in to do hospice, just for a short stay, but then
Right.
COVID hit, and so we
Right.
were dealing with that.
I just shot a quick text out to Kim, see if she has an answer for that.
okay, yeah.
That's a good question, so.
I think just having someone that you can go to get the information. When I first started this journey, I couldn't find any information and I was overwhelmed by my lack of ability to find any information. Luckily, I fell into PEG and then now I'm overwhelmed by the enormity of information I have, but
Yeah.
having someone that to say, oh, I have a new need. I haven't researched this. I haven't looked at this. This is my new need. And this person goes, oh, I have a resource for this or for that or for that. That's, wonderful to have that person that you can go to.
Yeah, you're right. And there is so many different ways this can go for each of us
Yeah.
for healthcare. But I mean, also to know that if you needed or you're interested in hospice, you can get a free eval, and have maybe a nurse come out and talk and evaluate. It doesn't mean if someone comes out, you have to admit.
Yeah.
Right.
And anyone can make a referral. Alyssa could refer me.
Right.
I mean, you know, anyone can make a referral. And then when they call the office, what happens is the people answering the phones will find out who the doctor is. They'll probably send a form out to sign for consents
Mhm.
so they can contact the doctor. Or if it's your loved one, you call the doctor and say, hey, I need records sent. That happens quicker.
Mhm.
And then they want to review everything prior to coming out so they get a picture and they know what's going on.
Right.
But, you know, maybe they come out and look and say, you know, right now, you don't meet that guideline, just a prognosis that someone could pass in 6 months. If someone does, then after 90 days, they get recertified.
Mhm.
Could this person pass in 6 months? And then it's every 60 days.
And
That's
if
how
they-
people are on for a couple of years.
If they don't, they're not just dropped off.
Right.
They can
Right.
go to palliative care.
Right.
Right.
You can go both ways. It's
Right.
far less frequent that they go from hospice to palliative care, but it has been done
Mhm.
and recently too. So,
Yeah,
yeah,
good
you're
point,
not
thank you.
just like, boop, bye, see you later.
Right.
And so you'll stay in the system. So then whenever they need to go back to hospice, we're right there. We're, you know, alerted quickly. And so that is a perk of having the companies within.
Yeah.
So. yeah.
And I used to tell people too about hospice, like, if you decide, you know, I want hospice, but then in a week you say, I don't want to do this, then you discharge. And then if you say, oops,
Mhm.
I think I need to readmit, you can, it's very flexible
Oh, yeah.
program. So I
Right.
think that people feel like, again, like you said, the H word is, just that word is really, it's scary, you know, but really it's the earlier someone gets on, it's better because the team gets to know them. So if they came out and I was on hospice and they knew me and I was acting different, and maybe they would say, something's going on, you're not feeling okay. But if they don't know me that well, you know, it just, it's better for each person on the team to get to know the patient, you know.
So can you kind of like tell, or there was this whole thing when I was at the Wesleyan, you know, people were on hospice. And so if they had an emergency, we had to call hospice. We never called 911. And then it was, you know, oh, well, can you explain the circumstances where somebody would actually go to the emergency room, or in all cases, if something happens to them, if they're on hospice, they just let them pass?
Well,
That's case by case.
yeah, it really
Yeah.
is. And if somebody wants to go to the emergency room and wants to go to the hospital, they can.
Mhm.
Hospice doesn't stop that. But we try to kind of talk about goals of care. What does this look like? And it may change from the moment they get on service. Yes, I want to call the hospital if anything happens to, okay, what happens if I don't want to go to the hospital? Because I think the fear for some people is going to the hospital, you're stuck there.
Mhm.
Then you can't get back home. And so how do we manage that? And that is good that they have, well, with hospice, we have on-call nursing 24/7, really. So if it's 2 a.m. and someone, their loved one's not feeling good, or that person's not feeling good, they can come in, or they can call and they can request a nurse to come out, or they have questions. But if someone calls 911, they can go to the emergency room. With hospice, we just hope that someone will call and let us know so a nurse can meet there and help with that.
Does that immediately discharge them from?
It should
No.
not,
Hospice?
no, but I have seen it with hospices, I've seen it happen where somebody meets them at the hospital to sign discharge paperwork, and
Yeah.
it's like, but they're going in for the same reason they're on hospice, so it should not affect that. I mean, correct me if I'm wrong, but if someone goes to the hospital for a symptom for the disease process they're on service for, it's covered by hospice.
Okay.
But they
It was
have
always
to have
very
a contract with
confusing.
the hospital.
Yeah, it was all very, Chris has a question. Chris?
Yes, hello.
Hello.
Can y'all hear me okay?
Oh, yeah.
Hi, wonderful. I was wondering if you could just give me a little bit more detail on the hospice in-home consult, kind of the process for that, what it looks like, and especially for a loved one who is potentially combative or in denial of the diagnosis, and what that would mean with someone coming into the home. Like how is that handled? Because that's kind of our situation right now, is where we need help and would love to accept help from either one of these organizations, but we're struggling with how to approach our loved one with being part of that help.
I'd say that's very common, first of all, so I wouldn't be too hesitant just because of your situation. Just know that that's something that we see a lot, so we do have prep plans for something like that. Right.
Yeah, and it's, if that person can make their own decisions, it's up to them. If they say, I don't want hospice, then, you know, you can't force it on them. You can't disguise who you're with. I mean, that is hard. I would say it's all about education and maybe just saying, we're gonna have somebody come out and just talk with us about this and what it is. And so they feel like they have a bit of control in that. But like Alyssa said, that is pretty common so how the process works is somebody makes a referral, whether it's the patient's family, a friend, whomever, the doctor, doesn't matter, but they're gathering that information in the office. They're getting medical records, they're getting an order for hospice before even coming out usually.
Okay.
So then the admission nurse comes out. And now her visit could be an hour and a half, 2 hours. It just depends on what's going on. So she's evaluating the person, looking at the notes, talking with them. At that point, if somebody says, you know what, I want to do this, they can sign paperwork right then. So, but yeah, it's hard because hospice isn't just for the person on service, it's for family as well. So it's kind of like, okay, we all need this. And again, I think saying, look, you're not locked in. If we start this and this isn't something what you want, then we can stop. Giving them that ability to say, you know, I don't know if I want to keep doing this. Sometimes knowing I'm not locked into something is better. I think I would suggest that.
Yeah, I think something too to keep in mind is, at least with Hospice Austin, we have people like myself, a team of liaisons that can come out to do an info visit. So for some of these, that's kind of the route to go to avoid that combative behavior, because we come in as a third party. We're not medical, we're not clinical by any means. And so we can just come in and speak about how the process would work. And we have been told before, be cautious of the H word. And so we can go in like, Shirley can't cover up our badge, you know, but we can say, you know, I'm here to tell you about, you know, like a nurse that can come out, CNA that can come out, physician that can be available to you 24/7 and see if that's an interest to you. And I just want to talk about your goals of care. What is going on, you know, why do you, you know, feel like you need this? What are things that you're looking for, or what does your family need help with that you can't provide? So this is just someone that we don't sign any papers. We don't, you know, sometimes usually at the end of the visit, we'll schedule the admission nurse to come out if everyone's and that's usually they can come out within 24 hours if needed. But yeah, I think that that's usually a good first step, if that sounds like something that they might.
Yeah, getting the physician on board that person is seeing, talking with them well, I mean, as well. So that way they can provide education. It's coming from them too, not just you.
Yes. The patient likes to hear it from the physician, not the family. They're like, they'll say, no. And then the doctor suggested, and they're like, oh, okay.
Yeah.
We get a friend guy.
Yeah.
It's right, but okay.
Right. Yeah, exactly.
So if there's a specific PCP or specialist involved that might be able to suggest it first.
Okay. And how do you guys deal with it? Maybe it's on a case by case scenario, but kind of this, you know, this window of like the 36-hour memory, and, you know, for a loved one who has dementia, Alzheimer's, having them trust a new person kind of coming into that home, but also forgetting who they are each time that they come there. Like, is that specific care that you guys are able to provide? Or
continuity of care, having the same people coming out helps with, especially with bathing too, you know, so personal, but our team is very sensitive to that. But again, is another reason why we have the same nurse come out, unless someone's on vacation or sick, same certified nursing aide, keep it consistent.
Yeah, I meant to touch on that too, the frequency of visits. So with hospice, so in this case, it would be, it's also an as needed structured plan. That's a case by case. Like if, let's say Susan needed somebody 3 times a week for bathing. Because if it's less than that, she's just not gonna notice them, or she's not gonna recognize them, then that would be something that we tailor to her plan. So 3 times a week-ish for CNA, is that right?
Yeah,
RN?
2 to 3 times a week, and
Times a
then,
week?
right, and sometimes,
1 to 2?
yeah,
1 to 2 times a week.
if there's something like specific going on, or, you know, they need it a little more, I've seen them do that as well.
Clinically, yeah.
Right,
Because the CNAs, they would help with like bathing, feeding, changing, things of that nature, and RNs can help clinically, medications.
yeah, they're
vitals.
the eyes and ears for the doctor,
Mhm.
and they're constantly communicating with the physician and saying, this is going on, or that's going on, and also having a volunteer come. You know, that's pretty big too. Now, they don't do any hands-on changing or anything like that, but they can provide brief respite, and they do it by zip code. So that helps as well, but it's like Alyssa was saying, it depends on what's going on. If somebody has something clinically, like they're needing more visits, then they will change the plan of care to allow for that. And then if everything gets leveled out, then it goes back to what it was. You'll have a nurse at least once a week, correct?
1 to 2 times a week, I
Okay.
think, depends on the case, of
Right.
course. And then towards the end, everything's gonna be more frequent. You're gonna see the social worker a lot more, you see chaplain a lot more. And then at the very end, they have a certain amount that they have to see so that we can be trained to predict when the final days are. So that they are supposed to see the patient within so many days, the last 14 days of life. So that's just so that we make sure we're not missing anything, and they just, you know, we do get surprised by a patient passing all the time, but that's part of the nature of the beast, you know, so we try to prevent that. Frequency of visit, let me talk about real quick. Palliative care frequency is far less, and it's just a nurse practitioner you'll be seeing, sometimes the medical director as well, but in that, the initial visit is close to 3 hours. And then every visit after that is substantially shorter, an hour and a half or so, usually twice in the first month, and then monthly from there, or it can be bi-weekly, and that is a huge ebb and flow. It's not consistent at all. Just because it's over years and years, and we have people on our program for 4 years. We have people, because we've been around 4 years, we have patients still from the very beginning,
Oh, that's
so
awesome.
it's not that common, but we do have them. So because they have such a long trajectory and prognosis, that they might see them then maybe once every other month too, when things are good, and when things are kind of, you know, going through the ebbs and flows, but pick it up a little bit more, keep on top of them, and there's symptom.
And there's a communication binder that's given when someone admits to service, and this is really cool, because if someone's working and they're not gonna be there for the visit, but they have a question, they can write it in the binder, and then whatever team person comes out, reads it, can write back, or leave a summary of their visit. And so that is a good way to communicate, to make sure everyone's kind of on the same page, or all the questions are being answered, or just a summary of what happened in the visit. And it helps the team too, because if the nurse is coming out from on call, she's looking through that communication binder as well as on the notes on the computer. But it's just a good tool to make sure that everyone's questions are being answered, and everyone knows what's going on.
Mary had said she's gotta jump off in a second, but oh, wait, it went up farther. Hold on. She said something else, and then the chat went away, went up. She said, my father-in-law is on hospice and he doesn't know it. He just thinks it's home health. He was a nurse, so we just say the doctor or nurse is coming to the memory care facility. So he's over at Platinum.
Which hospice?
She just,
Oh, okay.
is that what got her? She had to jump off, so I'm not sure.
Yeah, I think pretty much Altus is the one that goes in there.
Yeah, they definitely don't have to say hospice, but yeah, like Shirley said, sometimes our scrubs say it. or
Right.
The name tag, and remove
Mhm.
typically, but I mean, you can also
Yeah.
Yeah.
cover and not even know it, so.
Well, and I like what you said about when you are describing the members on the team and what they're doing. You don't have to just keep saying this hospice.
Right.
Yeah,
But
yeah.
the nurse will come out, the certified nursing aide, what are your goals of care? That was a good way to explain it.
Mhm. Where we can fill the need, it can be anything. It can be palliative care, you know, and I could say palliative care a million times and people forget the word all the time. P word I was referring to. I'm like, oh, probably
Yeah.
palliative, but yeah, you don't have to.
You know, with my experience with my mother, now I'm in a different thing, but putting her on palliative care gave us the opportunity, because she was so against hospice and everything.
Mhm.
Putting her on palliative care gave her the option to go, and then when it came time to go hospice, by that time, we had power of attorney. We were able to put her on to hospice, and she didn't see that she had gone on to hospice. So it was a movement from palliative care, and she was expecting visits at home and expecting nurses to come at home. We jumped into hospice, she still got the visits home. She
It
still
seemed the
got
same to her.
So she didn't know, so we didn't have to worry about her
Mhm.
being so incredibly combative. Because she was combative about everything.
Yeah,
So
that's
she
definitely
liked to have the
something.
nurses and people come to her. That was the reason that she went to palliative, because they came to her.
Yeah.
So would I.
Yeah,
And once
right.
we had that set up, then we were able to move to hospice without going through all of the.
Yeah, you don't have to jump through the hoops, you
Yeah.
don't have to get as much approval, and again, it depends on who the point of the power of attorney is. So who is making these decisions for them, and if it's the patient making the decision, again, we have to get that approval from the patient. But typically, that power, if it's close to the end of time where they're ready for hospice, that's shifted over to somebody that can make those decisions for them. But we do that a lot, so my hospice reps will call me all the time and be like, I have someone that's not, you know, they're very hesitant to say H word, they don't want to hear it, and then they'll send us in, and that's okay. The only thing is then sometimes it can be a not as appropriate referral to palliative care because they'll be on our services for maybe just a couple of weeks,
Mm.
then they go to hospice, but we do prefer that over them not getting hospice at all, so
But if they're
that's
a
fine.
combative person.
Yeah.
It eases it into.
Yeah, for sure.
Right, yeah. Good
Yeah, and
point.
we're very sensitive
Yeah.
to that, that's okay for sure, but that's something that the caregivers have to tell us, you know, when a physician is sending a referral and a really hospice program, like, come on, like, I feel like the doctors, they should be able to say, this is, you know, this is what you gotta expect.
Right.
Lay it on thick. But-
We had a new person jump on. Welcome, Jacqueline. If you wanted to unmute, if you had any questions, or type something in the chat. Chris, did you get your question answered? Do you feel like?
Yeah, I did. That was very helpful. You know, I'm also curious more about like the, you know, when you do have a durable power of attorney or even guardianship, like is there a point where the caregiver does have the option just to say like this is the help that we need? Or does that get messy?
Yeah, it's messy, but yeah, definitely.
Okay.
But yes, because at the end of the day, the only thing is when we've had this happen before, but patients can be so combative and so in a bad place mentally where they don't let people in the home.
Mm.
Then
I see.
we'll try a certain amount of times, but you know, we might just have to discharge and say we can't help. So, and that's unfortunate, but usually that's when the family steps in, and in those cases, there wasn't family to step in. So,
Mhm.
I got an answer to that memory care question.
Okay,
So memory care respites are out there, but they would be private pay, so they're not covered with hospice, but
Mhm.
you know, that's short-term things, so I think that's.
That's kind of what I figured. Okay, yeah. Okay, and Jacqueline doesn't have any questions as of now.
So one differentiator too, because the big question is like, where does palliative care start and where does hospice pick up? I like to picture it as like, if I could draw a timeline like we used to in elementary school, like, this is when I was born, this is when I died, you know, this is whatever. Palliative care moves through this trajectory of where a patient is still seeking any kind of treatment. Curative treatment, physical therapy, occupational therapy, lots of different kinds of treatment. They are working in an upward trajectory. They are still trying to increase their livelihood. whenever they want to stop treatment, stop chemo, these are qualifiers for hospice. And hospice can pick up right there. So what I like to make sure everyone knows is they never overlap. It's always like palliative to here and then hospice here to end. But they never overlap and there should never be a gap. Because when there's a gap, then things happen where hospice fall through the loops or you just want to make sure if you're not on Austin Palliative Care, you're with another palliative company that they are getting you onto hospice backed up. You know, they can't be same day necessarily, I think, but like the very next day, because you're having prescriptions that are getting refilled, you're having vitals checked. That's not something that you want to just drop off. So that's how it should look. And then of course with the company that it's combined, it will look like that, but it's so important because you just don't want it to be like, oh, we forgot, or we don't know who to contact. And so it should be streamlined one to another. Yeah.
And I think with palliative care, they can keep going to all their physicians.
Yes, yes.
Hospice
yes.
is, you're basically seeing the hospice team.
Mhm.
You can go for a consult, like you start feeling better and you think, let me go to my doctor, and hospice will pay for that. But they need to know ahead of time, right? So the billing is correct, but maybe you can resume treatment. So you start feeling better and you think, I want to go back to my doctor.
Mhm.
Let somebody on the hospice team know, probably the nurse, that you plan on going back to your doctor. So hospice can pay for that consult. And then if you can resume treatment or then just discharge. But with palliative care, you keep going to your docs, right?
Yes,
Okay.
yes. You keep all the
Okay.
specialists, you keep your PCP, but we communicate with them. So we make sure and send notes, visit updates, med changes, anything like that. Yep. And something specific for hospice Austin compared to other hospices is that any of those medical directors are only medical directors of Hospice Austin. We are the only hospice that can say that in Austin. Because, and why this is important is because when you are with a hospice and the medical director is dabbling in other hospices, other facilities, you know, they're doing a lot of different things and wearing many hats. Things can be overlooked. Things can be confused between hospices and rules, and this is just a huge benefit to your loved one, your caregiver that you don't even know about, that you will see in the quality of care. Because they have the time to then get on the weekly call with the nurses and discuss all the patients and hear and give their 2 cents, which other medical directors can't do because if they have their foot in 5 different hospice companies, they can't get on and talk about each patient. They're gonna get them confused. They're gonna breach of confidentiality.
That's a good point, and thanks for bringing that up. We have a list of questions that you can use to interview hospices. I mean, it's good to interview like 2 or 3 hospices, right?
I agree. Yeah.
You can send me an email at sprice@hospiceaustin.org. And I'm happy to send that list out, but you want to make sure that the medical directors are certified in hospice and palliative care. I mean, so they know the meds, they know the disease processes and what happens at end of life. It's not like an orthopedic surgeon. And they're like, you know, so feel free to email me and I can send that list out. But again, you know, trying to stay ahead of that and get all the ducks in line and say, I want to interview 3 different hospices. Let me see, what can you offer, right? And compare and see which one you have a better feel for, or you can ask specific questions. So I'm happy to send that to
Okay, yeah, I put it in the chat there too, so they could,
and I'll email it to you too.
Okay, cool. That's really, really good. Yeah, that would be nice to have on hand, or
Yeah.
maybe even put it on our website.
Yeah.
You know, this is good stuff. Anybody else have any other questions? You have anything else that you think this group might need to know?
Great questions. Y'all had some and good feedback. Thank you.
So Hospice Austin, is there any offices in Georgetown, or is it everybody comes in from Boston?
Right, so the care team, it's kind of like where they live usually. closest to that area,
Yeah,
wouldn't you
so we
say?
have good visit time wise.
Right.
In
Okay.
emergency situations.
We used to have an office here.
Mhm.
And we did it 2 different times, but community members weren't coming in.
Hmm.
So it was just our staff, which is great, but we feel like we could use that money better
Yeah.
to give back to the community. So we now no longer have an office here.
Mhm.
Our regular office is on Spicewood Springs, and then we have Christopher House, but everyone else is in the field going to
Out there,
visit.
okay. Well, I noticed y'all had .org, so nonprofit then?
Yep,
Yes,
nonprofit.
oh
Yep.
yeah, that's another, no big deal. We are the only nonprofit hospice in Austin as well, so.
I mean, we don't turn anyone away. I
Right.
mean, it doesn't matter what the situation is. Someone's undocumented, we'll still
Mhm.
provide.
Yeah,
care.
we visit homeless people. We find a place that's, centrally or
Right.
safe, I guess, to meet them. And we take unfunded patients. It's very like a specific number, of course, but yeah, we take unfunded because this is just something, it's a benefit. Nobody sees that. Or, I mean, they see it, but it feels like nobody sees it. You know,
Yeah.
they see it as like, oh, you're coming in to wrap things up and send my mom off and I'm not ready to say goodbye. It's like, you shouldn't be ready to say goodbye. You should still have 6 months or so.
Right, and it's what we've all paid in for.
Mhm.
Mhm.
You know, it's a benefit through Medicare. This is what everyone paid in for. This
Yeah.
is what we're
Yeah,
entitled
it's
to,
true.
really.
So for people who are just like, I don't want vultures, surrounding my house or whatever, what's the best way to kind of approach somebody, I mean, we talked a little bit about it, but the best way to kind of get that initial conversation started,
Yeah,
what would that look like?
For someone that's already interested and
No, for someone who doesn't really even know what it is, and then they may, the
Having-
person may anticipate that there might be some,
having a
pushback.
liaison
Yeah.
come out, just all you have to do is request an info visit. So it can be a call or we can just come out and it's just a non-clinical, non-medical
Mhm.
person like myself that would just come out and answer your questions. All the questions that we talked about, basically showing how it starts, like what the process is and what we need. And then also, just saying, we can help with that first step if you're ready too. Like while I'm here, I can schedule my admission nurse to come out.
yeah, someone that's going to the hospital a lot. And
Yeah.
they're not really wanting to do that.
Mhm.
Kind of opens the door. It's like Alyssa said earlier. It's not like we're saying we're not hospice, but not using that word a lot and
Right.
just saying, you know what, it'd be good to have somebody that we can call at 3 a.m. or
Mhm.
any time of the day when we're not feeling good and get some guidance clinically, or we actually need some help with bathing.
Mhm.
Talking about the team. Nice to meet you.
Bye. Sorry.
No, but talking about the services, the people on the team
Mhm.
itself. And you can go to hospiceaustin.org and get more information or ask for a packet. We can send you a packet. You can email me and I can mail a packet. But talking about, because you have a unique view into what that person might need.
Mhm.
So speaking to that and saying, you know what? Again, you're going to the hospital a lot. No, you don't really want to do that. How can we make sure that we keep you at home, but get the care you need?
Yeah.
That's exactly what it is. It's identifying the need or the purpose
Right.
here, and that's what we're gonna hone in on. That's what we're gonna talk
Right.
with the patient about. That's what we're gonna talk to the physicians about. What's their need? I'm not gonna talk with memory care physicians about like how palliative care helps during chemo. You know?
Right.
So,
Right. Yeah.
I'm gonna talk about how we help with dementia patients.
And there is no situation the same.
Right. yeah.
What my family needed when my grandmother was in hospice is what some different than somebody else. It's what that person needs.
And I want to say this before the end too, that I had, who was it? Someone with Hospice Austin that I love when he comes out, I forget his name, but he told us that,
Frank.
is it Frank?
Yeah.
He had a family member that passed on hospice and he had another family member that did not. And he didn't get to say goodbye to the one that did not pass on hospice because they didn't see it coming.
Mm.
And so while hospice is not like we're, starting the end of times, it's the beginning of the end, it's it does help people prepare mentally, you know, deep down, they know that means, okay, you know, mom or my husband or whoever is going to be going when it's their time, you know, at ease. And they can do the things that they need to do for closure. Everybody has what they need for preparation, whether it be like physically or mentally, spiritually, or just like calling up the grandkids to come say goodbye, you know? So yeah, there's a big purpose there for that as well. And yeah, when they're not on hospice, they can just pass and people kind of were in avoidance and they're in avoidance if they don't want to put them on hospice. And so yeah, there are just so many benefits to it. It's so important.
And it kind of helps to, if you're the daughter, you're the spouse, you can still continue your role, but have support. And you've got, again, like Alyssa's saying, a team that's telling you kind of what's coming to help guide you. But I think a big misconception is that we're there all the time, and we're not. I mean, people have their visits and they schedule that, but they're not there all the time, even though we're there to have support or have a on-call nurse come out in the middle of the night. No one is there all the time. So, you know, changing and turning and things like that, the family is still needing to do
But the bathing, y'all do the bathing.
the bathing.
But if
Yeah,
they wanted it more than that period of time, then they would just have to supplement it with something else. If it was more than the 2 or 3 days a week.
right,
Okay.
right.
And for patients that are in an assisted living facility,
Mhm.
you know, or memory care, or independent living even, that is fine, and we can still come out there, our nurses can.
Yeah,
work
that was a big
alongside
thing
them.
when I was an administrator. It's like, so is somebody, you know, well, hospice is supposed to bathe them. No, hospice is not supposed to bathe them. You know,
Yeah.
like the nurses, they were like, no, we thought hospice was gonna bathe them.
Right.
Kathy has a question. Hi, Kathy. You wanna unmute? We'll wait for you, unless you wanna just type it in.
Can I take a few more of these for my support groups? They always ask for one.
Can you guys hear me now?
Yeah, yes, ma'am. We got you.
Yeah.
Okay, what I have, Shirley is probably aware, similar to my situation currently. I recently had surgery and Mike did not qualify, was not eligible for hospice at that time. We managed to visit with a physician on Zoom the week before my surgery, and they elected to continue on with some of his treatment and more testing. And what I wanted to ask is, what this doctor did to me was kind of pass us to a social worker at Baylor Scott and White, where all his physicians are. And I'm at a point where I'm sitting here thinking, okay, now what can the social worker do for me now? And whether does Baylor Scott and White have the same stuff that you guys are promoting? Or just help me understand now where Kathy needs to go.
Yeah, so there's some, like, which location is it specifically?
I'm sorry, I couldn't hear you.
Which location, for Baylor Scott and White specifically?
Round Rock.
Oh, yeah, so, okay, I have just started going there. Actually, we have not been working with them in the past because they have their own palliative.
That's what I was afraid of.
They
Yeah.
have their hospice, but that's just saying that's why we haven't been marketing them specifically, because they have coverage, you know, we're reaching out to places that don't have their own hospice or palliative. But there are differentiators for sure within the hospices, and for sure with the palliative program. Their palliative, they don't go out into the home. Your question around the social worker, though, I'm assuming it's a case manager that was there for your surgery. They should have been someone to offer resources to you, like palliative care, home health, whatever is appropriate for your situation.
Right.
So who was I feel like I probably know who your social worker was.
You know, I honestly don't know at this point. I had 2 of them reach out to me after the Zoom call with the doc. So I didn't really respond. One actually called us, but I'm just I have connected with you guys and walked through this so far with you guys for 3 or 4 months now. And that's kind of where I just got left with these questions of, okay, do they have their own? Is that what they're trying to persuade me to do? You know, my main concern is my husband and having a safe team of physicians and people on his team. And until I had this emergency where I needed to put him in respite, I did not feel I had that team, and still question now, you know, where I go next for the sake of my husband's care. So I'm talking probably too much, but I just kind of wanted to get some feedback of, you know, next steps.
Sure. I was looking into Baylor Scott and White, specifically into their palliative program in the hospice, and then what the core differences that are between those two and then our two programs.
Yes.
And I do want to be their backup option so that they can offer patients options. That being said, it doesn't sound like they offered palliative care.
No, what I was offered was basically, we'll get a family member to come help you, which I did, but I needed more help than that. I needed someone to care for my husband for a few days. That was my first suggestion I got. And the second one was, or you can private pay, which is what I did and intended to do anyway, because I knew I needed the care myself. But it was just one of those situations that came up that I was a little bit lost, and Shirley and her team stepped in and guided me, and hopefully the next time will be much easier.
Yeah.
There's a lot of knowledge on hospice out there, but there is not much about palliative care, and there's very less about Austin palliative care. And there is, for right now, there's only one of me. So that is a hospital I go to now frequently because I live right by it, and my sister's been a nurse there for 15 years. So specifically that has been what I was targeting. So I am trying to work with them, but that being said, there is a big gap on what they have resource-wise. I'm sure they're not referring out to APC, Austin Palliative Care yet, or Hospice Austin regularly. So that would be something where you can go in and ask the provider or social worker, can I get a referral for Austin Palliative Care? And they can't say no, technically, but they can also, you know, then refer you to their palliative program if they need to, because I do think that that's an appropriate referral for y'all.
Right.
But you know that too, if someone makes a palliative referral and it's inappropriate, our nurse practitioner will then refer to hospice instead. So if they go in and say, or if our nurse sees it and says like, this is not a palliative patient, this is a hospice patient, then we'll make that referral in that recommendation as well. So.
Yeah, I have a buddy that works as a social worker for Baylor Scott and White Palliative Care, Jana Muniz. She's very educated. Sometimes it's hard to get into the palliative clinic. You know, it's hard to get Mike dressed and get him in the car and get him over there. And so she's usually pretty good about identifying that and when somebody can benefit more for being at home.
Yeah.
And if there's an urgent need and we can't make a quick appointment, we can always do Zoom as well. So it can be virtual.
I think me going forward, my plan, he's got a couple of follow-ups next week, and I'm just going to get a little bit more vocal and be assured that I've got the team communicating for him. So I think from hearing what you guys are saying, that palliative care is of interest to me, but I'm going to give it a week or two and see what kind of information I do get from BSW first.
Yes, and don't be afraid to ask. I hope you're not hesitant to ask, you know, be the advocate and put that out there. If the physician isn't recommending it, ask your own questions, you know, dig around and ask, what do you offer? What do you think if you don't, what I need? Do you have those resources? Do you know anything about Austin Palliative Care? I heard about them, you know, or if you have your own palliative, what's the best fit for our situation?
Perfect. Thank you.
And you can always call our company too. Just reach out, we can, like Shirley has said, we don't need a referral specifically. It's best if we have it, but what we really need are the records and the face sheet so we can just approve for insurance and approve for eligibility.
What phone number would they call?
Just the main line is fine, probably. Is it 512-343-7107?
342-4700.
That's what's on this one.
Yeah, and they can direct, and Kathy, you can call me too, and I'm happy to help initiate things or get a hold of Alyssa for the palliative care.
Yeah,
Great, that's a help just to keep moving forward, because every day's a new day. So,
Right,
that's our fax.
yeah.
Don't call 7107. You'll get them.
You'll dial into 1980.
That's the number I've given out 24/7.
Yeah.
All right. Anybody else have any other questions? We're gonna close out if is there anything we missed or questions you came in with that we didn't get to? Chris gives us a thumbs up.
And yeah, anyone that emails me, I'll send that list of questions to interview
Okay, cool.
hospices as well. And Kathy, feel free to call me again if I can help.
Great.
will do, thank you.
Yeah,
Great.
I'm
Yeah,
glad.
big thank you. Appreciate all the info.
Yeah,
Yes.
you're welcome. Y'all have a beautiful day. Thanks for tuning in. Take care.
Bye.
Okay, bye.
Bye-bye.
Sometimes I